Hi, Shabib, Isaac, can you hear me?
Yes, we can, Antina.
Yes, Anthony.
Excellent. Okay, so I think we can start. Hi, everyone. Thank you for joining. My name is Antana Dubamo from the Global Nutrition Cluster. I'm responsible for supporting countries on need assessment analysis and the HPC process. I have also with me Shabib and Isaac, whom I let to introduce themselves. Shabib, over to you, please.
Thank you, Antina. This is Shabib Al-Kubati, Information Management Specialist, working with Global Nutrition Cluster. Over to you, Isaac.
Hello, everyone. I'm Isaac Macha. I work with the Global Nutrition Cluster as Information Management Specialist for Rapid Response Team. Over to you, Anthony.
Thank you so much. For participants, as I have written at the chat box, please write your name, your organization, and your country and your role in your organization, or if you are a cluster coordinator or information management officer or a member of technical working group, please introduce yourself at the chat box. This webinar is going to be about 2 hours. We'll be covering the content you see on the screen. We will be focusing on clarifying the most recently published the global guideline for the humanitarian need analysis and response planning process, which was published recently, shared by Global OCHA. You can also refer to this guidance note at the chat box. Unlike the past years, OCHA didn't publish really a full package of HPC guideline. Instead, this discussion paper was published. So the webinar is mostly clarifying the implication of this discussion paper, which is a facilitation guide for nutrition need analysis at the country level. In addition, we will also be covering some frequently asked questions on the HNO and HRP process. So throughout the session, you can ask a question, just write at the chat box, and Shabib and Isaac, myself, will monitor the chat box and will address your questions. Yeah, so we can proceed to the content of Shabib. Go back to the previous slide. First, we will start with overview of the HNO-GF process, and then we proceed to the scope of analysis. There are new updates on how the scope of analysis should be done this year in 2026 HNRP. And then we spend most of our session on the nutrition sector need analysis and response planning. We will be addressing things like how to identify affected areas and population for nutrition needs, severity analysis within the nutrition sector, and we will talk about also the PIN estimation. And then finally, we'll cover the humanitarian response planning. Specifically, we will focus on how we set the targeting and costing. Next slide. So the HNO process, just to give you overview of the workflow, this is the GF workflow for the HNO process. It starts with identifying the contributing factors and defining the scope of analysis. This primarily does identification of the shocks, their impact, and affected population groups, and identifying administrative areas. Then this is followed by sectoral level analysis, which looks at the sector level severity of needs, and people in need within the sector. And then finally, intersectoral analysis is done. So we will not be, usually we cover these steps one by one, but today, as I already mentioned, we'll be focusing on the 2026 guidance note shared by OCHA, and we'll be also addressing the frequently asked questions. So next slide. So click, Shabib, there are some image, no, go back. Okay, so there is something wrong on this slide, but I try to explain. So the whole purpose of HNRP process is to identify the affected population, then determine the people in need, then set the target for the response plan for the year. So in the HNO, we should be able to identify who are affected in a particular country, which part of the country is affected, and the types of shocks. And then within those affected population, we need to identify the people in need. And then when you reach the stage of humanitarian response plan, we should be able to identify the people to be targeted for the 2026 response plan. So this is basically what we will be covering throughout this webinar. Next. So in terms of scope of analysis, what is new this year is there are what they are called core shocks that should be the basis for the HPC 2026 scope of analysis. So the four important shocks that need to be considered in HPC countries are: number one, conflict, violence, coercion, and deliberate deprivation of services; natural disaster, climate-related and geological shocks; epidemic, plant and animal pests and diseases. So these are the core shocks that need to be considered in HPC countries. So the impact of these shocks on population and basic service access will be evaluated, and based on that, the affected population is determined. So these shocks are taken into consideration in determining which part of the country, which specific administrative units, which population groups are determined to be affected by the current shocks. And there are some exceptions that are included in this year's global guideline. The following may be considered. Shabib, go back to slide. So on the right-hand side of the screen, you see those exceptions. In addition to these core shock-affected areas, areas receiving and hosting a high number of displaced people, meaning areas having IDPs, areas facing emergency level threshold of mortality and acute malnutrition, those areas having high acute malnutrition rate, regardless of whether or not they are directly affected by shock, may be considered for inclusion in the scope of analysis. And there could also be areas which are affected by major, sudden, acute economic shock. So this could be areas which are not directly affected by these core shocks, but they could be impacted by the overall socio-economic or the economic outlook within a specific country. So those areas can be included, but this is very exceptional, should be done with a lot of consultation with the humanitarian country team. Next. So now we go deep dive into the nutrition sectoral analysis. Next slide. So if I may start with this question, which one of the following would you consider as affected population for nutrition sector humanitarian need response planning in your country? So we have a case where areas receiving and hosting a high number of displaced people, areas or administrative unit with GAM greater than or equal to 10%, which are outside the affected areas as identified by the GF scope of analysis, areas facing emergency level child mortality, even though the area is outside the intersectoral affected areas are as identified by the GF scope of analysis. So which one of these, if it were in your country, would you consider as affected areas for nutrition needs? Please write your answer as the chat box. Multiple answers are possible, but please write at the chat box which one of these, if it were in your country, and if you are having areas outside the scope of analysis, meaning scope of analysis is about the areas affected directly by shocks, the shocks that I just mentioned earlier, and experiencing this situation: one, having high IDPs; two, high GAM; three, high mortality. Are these areas considered for inclusion in the nutrition sector? I see A, B, C, B, B, B and C, A and B, B all. I expect to see more answers because this is important. A, B, C, B and C, A, B, C. B is the obvious one. Yes. Okay. A, B, C. And B all. Okay. Let me answer this question. So, as you have seen in the previous slide, in the intersectoral guideline, it says, first, areas affected by the core shocks, which is the conflict, the epidemics, the pest infestation, and also areas with natural disaster. Those are like the primary areas of focus for the HNO. But there are some additional exceptions, which includes IDP areas, high IDP areas, which includes areas with high acute malnutrition, includes areas with high mortality rate. So these can be included in exceptional cases. So the 2026 HNRP global guideline gives us flexibility to include nutrition affected areas which fulfill all these criteria. So A is right, B is right, C is right. So these can be included in the affected areas for nutrition in your respective country. So this is, in my opinion, a flexible approach for including the critical nutrition needs. Next.
Hello, Anthony. We have a question.
Okay, please. Who is asking?
It's been asked by Koki from Afghanistan. Please clarify the exceptional GAM. Is this GAM work or WHZ or either?
Both. And for that matter, you could also use proxy GAM. Okay, we are in a situation where we are not able to conduct standard smart surveys, especially this year. So there is no expectation that the data should come from smart surveys. You could use, as we have been recommending throughout this year, you could use data from alternative data sources, whether it is a good high quality MUAC screening from campaigns, or it could also be surveillance data. Regardless of the source, so long as the quality is good, you could use GAM with MUAC, wait for height, or a combination of both. Thank you for the question, Koki. Okay. So again, I'm reiterating the point which I made earlier. For nutrition, the affected areas are areas affected by the shocks and included in the scope of analysis, in the scope of intersectoral analysis, meaning OCHA's criteria. I mean, OCHA in quotation, but it's intersectoral decision, which decides which areas to be included in the for as affected in the HNO, and then additional area which fulfill the nutrition sector's criteria, which includes high acute malnutrition. Here, when we say high acute malnutrition rate, greater than 10% with aggravating factors, and also areas with high IDPs, and areas which are experiencing economic shocks, but be careful, as I said earlier, the interpretation of impact of economic shock should be agreed at the intersectoral level. This is not a unilateral nutrition cluster decision. It has to be consulted with the intercluster level. Next slide, please. So now we go to the severity analysis. We do hope you are all familiar with these three scenarios of doing severity analysis at the country level. If IPC and IPC acute malnutrition data is available, you can use IPC acute malnutrition analysis for the HNO. If GAM level is greater than 5%, and if you have a global acute malnutrition data, then you can use scenario 2. Scenario 2 basically is analysis using GAM. So if you have GAM, global acute malnutrition data for most parts of the country, you can use that GAM data to classify the admin units by severity. The third and the most common one is using multiple indicators. This is a case where we do not have reliable GAM data, or the case where the GAM prevalence is less than 5%, we can use multiple indicators for severity analysis. So we will look at specifically the third one because it is the most common and the challenging and complicated one. Next slide. So the first process in severity analysis is, first we need to identify the indicators, which in another word, it means identifying the data sources. There are two ways that we can do this. First, we can look at whether or not we have a standard indicator. These are indicators where we have global severity reference table. For those of you familiar with the GNC guideline, you know that we have a table, a reference table, which lists the HNO, HNRP indicators and their severity and the different severity threshold. This, for example, includes MDD, minimum dietary diversity, minimal acceptable diet, GAM, morbidity, immunization coverage, and so on. And as we have been saying over the last years, the GF 2.0 allows for use of proxy indicators. So the most common one is using proxy gap from MUAC screening data. You could also use other proxy indicators. Next. So this is the reference table for standard indicator selection. What you could do is you look at the GNC list of indicators, and you can look at the different severity threshold. If you have these data sources, and if you have a data source for these indicators, you can automatically use these standard indicators for severity, and the process of severity analysis is very straightforward. You look at the reference, and if the severity matches the severity threshold you see on the screen, then you rate each administrative unit using those severity levels. Next slide. However, the current reality is that we were not able to, most of these standard indicators, they come from standard surveys, as we all know, because of significant cut in funding and resources. Most countries do not have the capacity to conduct standard household surveys. Instead, we are faced with the reality of using alternative data sources or proxy indicators. So what this implies that we need to make sure that those indicators are recalibrated, meaning even if you can use those, even if you can identify proxy indicators, you may not have global reference for proxy indicators. The global reference you have is for proxy, for standard indicators. So let's say in your country, you have selected 3 indicators for severity analysis of malnutrition risk. One could be number of IDPs per admitted unit, percentage of diarrhea morbidity among children who visited under 5 clinic, and you also included micronutrient supplementation coverage. Obviously, there is no severity threshold for these indicators. Now, the question is, how do you determine the severity threshold in a scale of 1 to 5 for these indicators? I think this is a very critical question. We know that most countries, they apply proxy indicators by consensus. You consult with your partners and you come up with those indicators. But when it comes to designating the severity of those indicators, it's a challenging exercise. So if I may ask you again, how do you determine the severity threshold from a scale of 1 to 5 for example, for these suggested indicators? Any response, please? You can write at the chat box. And we are also willing to give a chance for a couple of people to share their experience, because this is very important, especially in 2026, where we do not have sufficient data which will enable us to use the standard indicators. Now it is more likely that most countries will be using proxy indicators. So anyone who has experience in calibrating proxy indicators, please, you can respond as a chat box. And also you can raise your hand so that we can give you a chance to speak. Okay. All right. So I do not see any response at the chat box, so which means that I can proceed to the next slide and clarify how this can be done. Next slide, Shabi. So if we are in a situation where we have no option but select proxy indicators, there is a process of contextualizing the indicator and calibrating its severity. This is clearly allowed and recommended in the GF protocol. So first you look at whether or not you have data from standard indicators, standard data sources such as household surveys like smart surveys. If you don't, then you can select proxy indicator, as I said earlier, from alternative sources. Alternative sources are any sources with a reasonable quality, but they are not like a conventional household surveys. So you can select the indicator from those kind of data sources. Once you select the data sources, you should align the severity, the levels of those proxy indicators with the 5-scale severity level. So I will show you on the next slide the 5-scale GF severity levels. So for example, if you select, let's say, the IDP numbers as one of your proxy indicators, the IDP number, for example, it could be 500, 1,000, 3,000, 10,000, 50,000, and so on. So depending on your country, you may have to make some subjective expert assessment of which number of IDPs corresponds to the different levels of severity. If in your case, 50,000 is really the most severe number of IDP concentration or the number of IDPs per admin unit, you could assign severity 4 or severity 5. If 10,000 is just a very common number of IDPs by admin unit, then you may have to decide whether you put this severity as severity 3 or 2 or 4. So it depends on the context. Next slide.
Hello, Anthony. We have another question from Inchi from Haiti. How old should the data be for a proper analysis?
Inchi, this is a very important question. In the GNC tool, which Shabi will be showing us, there is a data source quality assessment sheet in which you look at the recency of the data, whether or not the data is recently collected, and the robustness of the methodology, meaning whether or not the data source is of good and acceptable quality, right? So there is no really specific, clear-cut time frame for recency. This is, again, GF allows for expert assessment. You could consult with your partners and you can choose whichever makes sense in your context. But the most recent and timely data is obviously recommended, and also a data coming from standard sources or from household surveys is recommended. In the absence of these sources, you could look for data from alternative data sources. So this is more of a consensus-based decision. I cannot put a specific time frame for the source of the data, but recent and reliable sources are, as always, recommended for use in the analysis. All right, next. So, as I mentioned earlier, whichever context-specific indicator we select, we need to align the degree of severity with this global standard. This global standard is made to be generic without specifying the specific sector, specific location. It just only shows you the level of severity for a given indicator. For example, severity level 5 is where we see extreme level of severity. For example, a complete collapse of basic service or total inability to meet basic sectoral needs. So taking the example of the IDPs, the IDP number that I mentioned earlier, if the number of IDPs is to an extent that will result in a complete collapse of services in a particular admin unit, this is more likely severity 5. If the level of IDPs is, although it could be a relatively large number, for example, let's say 10,000, but it is not resulting as a complete collapse of services, or the service available within the admin area can absorb the number of IDPs, maybe the severity could be level 3 or level 4, or maybe exceptionally level 2. Say, for example, you have an admin unit, let's say, with let's 500,000 people, a big city, and 5,000 or 10,000 IDPs move to that area. Obviously, they have the need as a population, but in terms of affecting the severity of the need in that particular area with a population of 500,000, I would say is really insignificant, given the size of the admin unit. The influx of 5,000 or maybe 10,000 population may not significantly impact the overall need for services, and it may not at all result in collapse of services. So you can make those kind of assessments in a consultative manner in your country, and then designate the severity levels of indicators that you select as a proxy indicator. I see one comment from Geraldine at the chat box. Although OHI in countries highly recommended data that are maximum threshold. Okay, yeah, that's really a good point. Again, this is the most recent data is preferred in almost all cases. We can see some countries even using older than that, but it's not recommended. But if you do not have option, you may have to go back to a couple of years, or you may have to look for data from alternative data sources. Yeah. So thank you for this point, Geraldine. Okay, next slide, please. So this is the severity analysis part, how it looks like within the GNC tool. So I will let Isaac to take us through the process of using multiple indicators and conducting severity analysis. Over to you,
Okay.
Isaac.
Thank you so much, Anthony. So in terms of this slide, we'll be looking at the scenario 3 in the worksheet, where it looks at using multiple indicators with weighting. And mostly, this is when the GAM levels are relatively low, which is less than 5%. We know scenario 2 is looking at GAM levels greater or equal to 5%. So in this one, we are looking at GAM levels that are relatively low, and there is no available data or survey, and thus there's still limited nutritional vulnerability or contributing factors that are required for the analysis and response. Thus, for the GAM outcome that remains our primary focus, in the other scenarios, in this one, we are looking at a broad set of core nutritional and contextual indicators being used. Key examples of some of these contextual indicators are stunting, dietary diversity score, anemia, morbidity, immunization coverage, or WASH, or any other indicator that might be contextually related as well. Here, we'll be looking at a preliminary scoring system being applied, and weighting is done across various different indicators based on the assumed vulnerability and the reliability upon which they are being used. So this helps additionally to classify on the severity level from phase 1 to 5, and even when the GAM is below 5%. So in terms of the weighting, they are grouped into 3 key areas. 55% of the scoring comes from core child indicators, which are either exclusive breastfeeding, dietary diversity score, stunting, overweight, or anemia in children. 30% of the score is towards infant feeding practices, looking at either non-breastfed with BMS support, anemia in women, or any other indicator that fits under infant feeding practices. And then the last grouping is composes of 15% from other vulnerability groups, which are either older people, adolescents, or plus a small slot of country-specific inputs, depending on the vulnerability scales that have already been defined in country. So based on this holistic grouping of 3, we get a full 100%, which helps now in categorizing the various phases across which you will define the severity scale. So in terms of the scenario 3, there is a worksheet that is provided that provides the key scope of how the weighting has been done. And we've realized some countries might have very key areas that they are looking at, and the indicators might be limited based on what we are currently providing in this list. And I think Antony will be coming again to chart the way forward in terms of any adjustments to this scoring that can be done. Over to you, Antony.
Thank you very much, Isaac. Next slide. So what Isaac showed us is what you see on the GNC tool. There are a list of standard combination of multiple indicators other than GAM. And we have already predetermined the weighting for these indicators or a group of indicators. And then you just put those indicators in your country if you have those data for those indicators, and the tool automatically generates the severity. However, especially in the last recent years, and we would expect also in this year's HNO analysis, that most countries do not have this list of indicators. It's very difficult to get data on all these 10 plus indicators and do weighted analysis using our tool. So we are now suggesting using multiple indicators, but also adjusting the weighting depending on your country context. So again, I would like to raise this question before I move to the next slide. Let's say in your country, the cluster selected, by the cluster I mean here your analysis group, you selected minimum acceptable diet, acute food insecurity phase classification using, IPCA-5, and the number of IDPs per admin unit, percentage of diarrheal morbidity among children who visited under 5 clinic. So you selected these indicators as your indicator for severity. Now, the main question is, do you give equal weighting for these indicators? As you can see, there are 4 indicators. Each one will give you different severity, or it could be the same severity, but do you give equal weighting to each one of these indicators? I think this is a common challenge. This is a commonly asked question, a frequently asked question, to which we provide guidance. But I would like to hear from you. You can write as a chat box. do you think you should give equal weighting for these indicators, or do you recommend giving different weighting for these 4 indicators? What I mean by weighting is, for example, if you have these 4 indicators, if you want to aggregate the severity, and each one of them, they have, let's say, 4 severity level, simply the aggregated severity level will be 4 plus 4 plus 4 plus 4. So 4 times 4, 16 divided by 4, it gives you 4, which is, we are assuming that each indicator is equal, and it is, let's say, impact in quotation. So we treat each indicator as equal, then the severity level should be the average of the 4 severities. Go back, please. So in your experience from your country, which way do you recommend? Do you use these indicators in equal weighting, or you should apply varying weighting of those indicators when you do your severity analysis? I hope my question is clear. If not, I'm happy to clarify first.
Hi,
Regina,
Antonio.
yes, please. I see
So
Regina's response.
Yeah, and also we have a hand high from
Raised by
Isaac.
Isaac.
Yeah.
Okay. Thank you. Okay. Regina says, I think child-specific indicators such as minimal acceptable diet and percentage of children with diarrhea should carry more weight. Could be. Yeah. You could apply varying, or you can give more weighting for this nutrition specific the minimum acceptable diet indicator and child morbidity. Yeah, could be. So Regina is suggesting we know is recommended to apply some varied weighting for these different indicators. Okay. Let's go to Isaac. Isaac, over to you, please.
Thank you very much, Anthony. I think if for Sudan,
can we
for the time being.
Can you hear me, please? Can you hear me?
Yeah,
Isaac?
he's already unmuted, Anthony. He's
Okay,
unmuted.
go ahead,
He's
please.
already speaking. Oh.
Go ahead,
Yeah,
Isaac.
thank you very much, Anthony, and the team, and thank you for this, webinar. I think it's very important to have that kind of a global understanding for everyone. To respond to the question, I think Hashim is here. In Sudan, we use 3 kind of indicators. We use the dietary diversity among the under 5 children. We use the acute food insecurity. Previously, we were using IPC. And also we use the GAM. So the weighting we normally use, we give more weight to the GAM because that's the main concern for us. And I think food insecurity and dietary, they normally share the same level. So we normally, for example, give 0.4 for a GAM and 0.3 for each of food security, severity, and of course dietary diversity.
Okay, thank you. Thank you, Isaac, for that. So you give different weighting for different indicator based on your assessment of which one of the indicators are more important in terms of assessing the severity, right? So in your case, you have GAM data of some reasonable quality. You think that you should give more weighting for GAM. Okay.
Exactly, and because it's also the main nutrition issue, the severity is about nutrition. So if we have we want that kind of a nutrition situation to come up a bit more stronger than the other. Thank you.
I agree. Thank you. Also, I see a response from Helena. Helena wrote, is it okay to use a calculated SAM proxy based solely on routine admission data in areas where smart survey are not available? So I guess this question is about, can a proxy sum data using routine admission, proxy sum or proxy gum using admission data be used in the absence of smart survey data? The answer is yes, but it depends on the quality. Using alternative data sources doesn't mean compromising the quality of the data. So and we now have some ways of assessing the quality of data. For those of you who participated our past webinars on this subject, you know that there are some quality assurance mechanisms for alternative data sources. So if you apply those quality assurance mechanisms for any alternative data source, yes, you can use those alternative data source. And you can assign a proxy indicator, whichever is applicable in your case, but make sure that the quality meets at least some minimum standard. And I see also another comment from John. Has the IPCJSU finalized protocol for IPC-FIMN prototype testing, which would inform persistent food insecurity and malnutrition analysis? This would support in ongoing transition in some countries, especially government-led assessments and IPC processes are taking place. I don't think, as far as I know, as far as we know, this work has not been finalized. What I remember is we had some discussion on the degree of correlation between this, the FIM findings in the past. And I think one of my colleagues here, Amadou, and myself, together with our coordinator, Stefano, we looked at, based on historical data, do we see any positive correlation between the FIM and severity scale? We couldn't find any consistent, conclusive finding. So for now, we cannot say, based on AFI, we can confidently say that, the level of severity of acute malnutrition is higher, simply because the severity of acute, the severity of AFI is higher. So we haven't reached at that conclusion, but this is an area which we could explore further. I hope this answers your question, John. Okay, so let's go to next. I cannot see the slides, Isaac, Shabib.
It's currently showing on my side, Antene. Probably you could.
It doesn't.
You could log off and on.
Okay. Yeah. Okay, now it's back. Okay, so as you have responded, we apply weighted severity analysis in most cases. And so the next question is how? How do we apply this weighted severity analysis? Because there is no standard formula plugged in our tool. So this slide is meant to demonstrate how you can do that. We are happy also to have a one-on-one call with you to show you how you can do weighted analysis. And I guess we recently had a call with DRC, with Amadou, who is supporting DRC. So in the first table, what you can see is, if we assign equal weighting for say, for example, 4 indicators here, the severity could change. Like, for example, minimum acceptable diet is 3, and the rest of the indicators are 4. And if you give equal weighting, obviously, the severity is going to be severity 4. If even if the minimum acceptable diet, which is really very nutrition-specific indicator, the severity is high. If we apply the same weighting for other nutrition-sensitive or nutrition-related indicators or nutrition-relevant indicators, the severity may be below the nutrition-specific indicator, which in this case is minimum acceptable diet. So the first table shows that when we do weighted analysis, we need to be careful because the severity of other indicators may sometimes suppress the contribution of nutrition indicator, nutrition-specific indicator, or sometimes it may appear the severity, the overall severity is less than the nutrition-specific severity. So in this case, in admin area B, in the first table, you can see the minimum acceptable diet is severity 4, but we have introduced 3 additional indicators, and they are severity 3. And if we give equal weighting for all of these indicators, the severity becomes 3. So I don't think any one of us would say, you know, this is really a good assessment of severity of the nutrition need, because to some extent, the severity level of malnutrition is influenced by other nutrition-related indicators, but the severity eventually became less than the nutrition-specific indicator severity, in this case, minimum acceptable diet. So I don't think this is really a more favored approach. So which means is that we should use more weighting for the more nutrition-specific indicator. This is not a prescription. This is a general recommendation. You can decide in your respective country whichever makes sense to you. But overall, we recommend you give more weighting for the more nutrition-specific need, and you give less relative weighting for the other indicator. So in second table, we assign 75% contribution for, sorry, it says proxy gum. You should please replace it with minimum acceptable diet, and 10% for morbidity, 5% for IPCFI, and 10% for IDPs. So that changes the severity level more close to nutrition-specific indicator. I hope this is clear, but we are happy to have one-on-one call and to clarify this weighting process specific to your country. But let me know if you have any question or if you need clarification. Isaac, is there any comment or question at the chat box?
No, we don't have any questions, Anthony. I can move ahead.
Okay. I hope it is clear, but the point here is you can apply weighted severity analysis in case where you are using multiple indicators and whether if these multiple indicators are especially proxy indicators. Next slide. So now we move to, we covered severity analysis. Now we go to PIN estimation, people in need estimation for the nutrition sector. Next slide. So let us look at this small exercise. Which one of the following meet the GNC or the GF or the HNO nutrition emergency in PIN definition? Which one of these do you think fulfills the GNC PIN inclusion criteria? First one, children under 5, pregnant and breastfeeding women, and other vulnerable groups who are acutely malnourished, at risk of becoming acute malnourished, who live in areas affected by humanitarian crisis as defined by scope of GF HNO analysis, meaning children under 5, pregnant and breastfeeding women, and other vulnerable groups who are acutely malnourished and living in scope of analysis areas. That's one option. Another one, all acutely malnourished children and include here pregnant and breastfeeding women across all parts of the country, regardless of whether the area is affected by crisis or not. So regardless of whether the area is affected by shock or not, if they are acute malnourished, they have to be included. C, children under 5, pregnant and breastfeeding women, and other highly vulnerable groups living outside affected areas as defined by the scope of analysis, but who are acutely malnourished or at risk of becoming acutely malnourished and living in areas acute malnutrition is above emergency level. So even if it is outside the affected area, so long as acute malnutrition rate is high or above emergency, you could still include them in the PIM. D, children under 5, pregnant and breastfeeding women in areas receiving and hosting high number of displaced people. So I see a response at the chat box, all applied A to D, ACD, AC and D, AC and D, CD, ACD. So based on, we actually talked about this in at the beginning of the presentation in the scope of analysis section, that all areas included in the GF or HNO scope of analysis. The scope of analysis, remember, is the intercluster decision to identify areas affected by the crisis. So any need within the scope of analysis areas is automatically included in the PIN. The second one is any acute malnutrition case load in the country, regardless of whether it is affected or not, should be included. This is not correct. It's only areas with high GAM outside the affected areas as defined by the scope of analysis can be included. So we cannot say, you know, we have 5 million acutely malnourished children in a certain country, and that can be the PIN for nutrition needs, whether or not some of the admin areas are outside the affected area and their GAM is, let's say, below emergency level. I think that that's not acceptable, and based on the current GNC GF definition, only the need in high acute malnutrition rate areas plus areas which are designated as affected are considered to be included in the PIN. So A, C, and D are correct. Next slide, please. Okay, the next question is, what kind of service can we include in the PIN? Can we include preventive treatment services, and which one of them can be included? I think this is most frequently asked question, and I would like to hear from you, what kind of services do you normally consider including in the PIN? You can write at the chat box. Obviously, we have the CMAM services. We have the, let's say, blanket supplementary feeding. What else you can consider including in your PIN? This is very important because some countries, they have a very comprehensive list of services included in the PIN. Some countries include maybe a couple of services, not more than 3, 4, 5, and typically CMAM services. But it would be good to hear from you, which kind of services do you consider including for inclusion in the PIN? Please list. You can list as the chat box. BSFP and treatment, CMAM, micronutrient supplementation, MIYCN counselings, IMAM, MIYCN, BSFP, vitamin A supplementation, IYCFE, micronutrient supplementation. Yeah, so these are the common ones. Some of these need to be unpacked. For example, when we say micronutrient supplementation, what do we mean? Is it the vitamin A or another supplementation program? That need to be clarified. And also inclusion of cash and voucher support. Yeah, this is also one modality. NNP, SQLNS, raising awareness, mass campaigns. Okay, let's go to the next slide. So we have what we call the Essential Nutrition Action Services list. This is included in our GNC guideline. It lists all possible service types that you can consider including in your HNRP. So you have a list of services for infants, children, adolescents, adults, and older persons. So there is an exhaustive list of services, both treatment and prevention. So you can basically consider all these in services depending on your context. This is context dependent. So the general recommendation is make the service as comprehensive as possible, meaning combine treatment and preventive services. And secondly, make sure that these services they meet to the most part the life-saving criteria of SURF mechanism. For those of you who are familiar with the SURF has list of services which are considered as life-saving. This is a funding allocated for filling the gap in exceptional situation, and it lists the various type of services that can be funded through the SURF mechanism. The more you include life-saving services, in our case, almost every service we provide, we listed in our guideline is considered life-saving. For those of you familiar with the SURF in the past, the SURF only includes basically treatment services as life-saving, but that is not the case now. In the revised SURF guideline, we have included preventive as well as treatment services. In fact, actually, surveillance is also, surveillance/assessment is included as a life-saving service. So we are in a good position to include as many services as possible. Okay, next slide. Now, once we selected the service package, the next step is how we can use the GNC PIN estimation. I believe this is a very good tool and it makes your life easier. And Shabi will take us to the tool and demonstrate how we can use the tool for estimating the PIN, even estimating the supply need, and to some extent also how we can make an estimate of the cost of those services. So I will hand it over to Shabib to take us through the GNC tool.
Thank you.
Over to you, Shabib, please.
Thank you, Antina, and hi everyone. So we will go through these tools. This is humanitarian need analysis. Everyone, I think, in the countries, they are used to adapt with these tools and they use it. And we have discussion one-to-one with some countries. So how you can do the people in need calculator. So we will go through different steps. So the first step, it will be define population group and area. So first of all, you will identify nutrition vulnerable group, for example, children 0 to 59 months, pregnant and lactating women, adolescent, older people, or other vulnerable group. How we bring this data? Directly use the population figure for affected area, provided sometimes by OCHA, IM working group, and also sometimes from CSO, the Statistics Center or government, they can provide for you this affected area. The second thing, it would be preferred that we disaggregated this data by age, by sex, and disability where possible. So even in the tools, you can find that even we have children 0 to 59 months, but also we disaggregated to be 0 to 5 months, 6 to 23 months, and this for different age group. This is for first step. The second step also, we will select our nutritional needs and services. As mentioned by Antina, that we have a different package, but for example, the tool will support you to calculate the acute malnutrition, IOCF practice, and micronutrient deficiency. So for example, for acute malnutrition, it is over to you how you can select, how you will come up with the people in need. We have in the table below, you can see 3 options. The first one is by coverage. If we have last year data, admission data, so we can predicate for next year using the coverage from last year. So this is the tools, now it's included this feature. You only just enter the last year SAM privilege, MAM privilege, and also next year, this year and current year as the privilege. After that, you also include the last year coverage, which is the admission, and the tool, it will automatically calculate for you the estimation people in need for this year. You can see this example. The other 2 options, it is just using the incidence factor, how it is, how we are usually adapt to use this tool in the previous year. So this is the step 2. Step 3, the step 3, that's tool. Once you enter all this information, the tools directly will calculate it for you. It will calculate for you, for example, the wasting, SAM, MAM, it will calculate inpatient, outpatient, target supplementary feeding, a number of children in need of screening, also women. Also, it will calculate for you micronutrient deficiency. So what you will do, some of this, in the tool, you can find it that some of this cell highlighted in below, please fill this by prevalence or the coverage gap, and the tools will give you this information about micronutrient deficiency, like for example vitamin D or whatever indicator like anemia. Also for IOCF indicator, this tool also will calculate. So only one task from you, just to fill the first sheet, which is called population figures. After that, the tool will support you to have this caseload. The third things, generate people in need estimation per need. So the tool also will support you to have the people in need per these different categories, which is wasting, treatment, IOCF need, micronutrient, and it will calculate for you the total people in need. Please try as possible as you can disaggregate the data by sex, age, disability, and geographical area. So if you go lower the admin 2 or admin 3, it will be better. So once it will help you also when you design your monitoring and evaluation tools, you can see how coverage or how rich target against pain in this area. 5. Consolidated and validate. Please ensure also consolidate total across nutrition need into nutrition people in need total. Cross-check with intersectoral analysis GF2 for alignment. Validate through consultation partner and document assumption. So, for example, default stability rate is 10% if no data. With discussion with partner, you can come up with missing data or discussion. So this is step 5. Step 6, you come up with the target. So based on your people in need, you can see the humanitarian access constraint like insecurity, services delivery barriers. Also define the target. So sometimes you have people in need. So maybe you will come up with the target, the percentage from the people in need, and sometimes by location. But it depends also about humanitarian principle if there is no funding or capacity. And also the last things in these steps, it is calculate supplies and cost. So the tools, once you have the people in need and the target, the tools will support you how the supplies you need. The only information you need to enter in the supply sheet, it is just the target. So for example, if you have 100 child in need for therapeutic, so you can select the percentage if they are 100% or not. Also the duration in month, we know some supplies you can have it for 3 months, some supplies for the whole years, and some supplies for the child until recover. The unit cost, it has this tool, it has the updated unit cost until today, but sometimes if this unit cost change, please just update it from UNICEF catalog. And also ensure that you enter the unit available and units in pipeline to find the gaps, how many quantities gaps refer to this supply. So after that, we can come up with supplies required, the total cost and funding requirement. So this is overall the steps. And as mentioned by Antina, we are here for any discussion one-to-one to explain it more. Thank you.
Hello, Shabib.
Yes.
Hi, Anthony. We have one question where it is asking, Motasim from Cox Bazar is asking, which path is better to calculate the PIN, using the admission data or incidence factor?
All right. So, Shabib, would you like to answer or you would like me to respond?
Yes, you can.
Yeah, you can go back to the previous slides. I think slide number, yeah, this one. So, I guess the question is, which path for estimating the PIN for wasting? So for wasting in particular, we have 3 options. If you have a very reliable admission data from previous years, and if there is a direct measure of coverage, when we say direct measure, is a measure of coverage that is determined by using coverage survey. If you have that kind of data, you can use option 1, which is estimation of the people in need for wasting using the coverage in the preceding year. That's the most recommended one. This is recommended by the the global NIS GTWG, Nutrition Information Technical Working Group. Option 2 is the context-specific incidence factor. In order to estimate the PIN for wasting, you take into account prevalence caseload, meaning the caseload you expect at a point in time, plus incidence caseload, meaning the number of new cases that you would expect to emerge during the 12 months period, usually. So you combine incident and prevalent cases, and in order to do so, you need to account for incidence factor. So if you have country-specific incidence factor, which we have for several countries, you can apply this context-specific incidence factor. In the absence of context-specific incidence factor, the option we have is, which is the most common one, which is using the global incidence factor, which is 1.6 times the prevalence. So you can use one of these options depending on availability of data in your context. Kutab. Kutab, can you hear me?
Yes, I can hear you. Can you hear me, Ntene?
Sure. I can hear you.
Yeah. Yeah, actually, my question is regarding the entire pin. When we are calculating the pin for the cluster, usually we are facing what we have seen three kind of problem issues. Number first, for example, sometime when we are combined, there is a duplication of beneficiaries. For example, if you are putting SAM plus MEM plus BCP, so sometimes you will find a duplication of that one. The second issues usually we are facing sometime, for example, if you are taking vitamin A, some countries we have seen it, they are taking the maximum numbers in children to avoid this duplication in beneficiaries. So what's issues we are facing there, that sometime when you are progressing, your progress is not aligned with the costing, with the budgeting you receive, and sometimes you will feel that with the 20% of funding, cluster funding, you will able to reach like 80% of the cluster pin. So these are a few things when we are putting combine all the combined pin people in need. So in Afghanistan, what we are doing, we are dividing the first children. So for example, in children we are taking treatment program like SAM plus MEM children, and then BCP. In area where we have more BCP, we are taking maximum in children like SAM children and MEM children, and in BCP. And the same for pregnant lactating women. Like usually we have seen MIYCN is usually we getting more numbers there. So, but we put a formula there that BCP again is our preventive intervention. So we are taking like maximum in treatment and in preventive activities. So in this way we are calculating our pen. I don't know, to me, to be very honest, these the standard formulas we are calculating same children and MEM children. But when we come in terms of the entire calculation for pen, we have seen different countries are doing different things, and I think we need to come up with a standard formula for this one. I have also seen that like in Afghanistan, vitamin A supplementation we are not including in our caseload calculation, and the reason was previously, usually in campaign, usually we are doing, so we reach like the target, the pin in the first semester. Sometime you will able to see that we reach our 100% of the pin. And when you align our costing, funding for the cluster usually is not aligning with our beneficiaries. So this is also one of the issue. I think I'm requesting if we can get a clear direction on this one. We'll be obliged. Thank you very much. Over to you.
Thank you, Kutab. Yeah, you raised very relevant. In fact, actually, some of the questions we included in frequently asked questions, which we will be going through shortly. So you mentioned about aggregating the PIN, how we can avoid duplication, how we can avoid double counting. This is a very common problem. We will discuss that briefly in after a couple of slides. Very important question. And also, you raised an issue which looks to me more to do with setting HRP target. You said, how can we set target in a low funding prospect, like in a situation where we are right now? We are not expecting a lot of funding, or we are expecting far less funding in the upcoming year, and do we still stick to this high coverage of the PIN or setting high percentage of the PIN for HRP target? Does it really still make sense? I think this is a very important question for all of us, how we can set our target. What is the basis for determining that? I think it's a very important question. We have a couple of slides on HRP targeting, and the global guideline has provided some recommendation on what percentage and which severity levels should be targeted for HRP. So we can discuss that also later. You mentioned about vitamin A is not included. Yeah, that could be the case. In some countries, campaigns are run by Minister of Health, and only in exceptional cases we include vitamin A supplementation campaigns. Only the gap not covered by the campaign is included in the PIN. So we will address this and similar questions in the FAQ section of this slide. In the next couple of slides, sorry. Okay. So yeah, so FAQ. Should we include 100% of what, in the list of services, we can consider including vitamin A supplementation. Now, the question is, should we include 100% of the vitamin A supplementation need in the PIN? Please answer as the chat box, yes or no, or maybe could be an answer. In your country or in your past experience, did you include 100% of vitamin A supplementation? Kutab already responded that they don't include vitamin A supplementation. He didn't mention the reason, but I assume that maybe this supplementation is provided by biannual campaign or routinely, but for some reason they don't include vitamin A supplementation as a PIN. Okay, Helena says no. I honestly, I would like to hear from most of you because this is a common question, and it would be good to hear from you. I mean, there is no really right and wrong answer. It all depends on the country context, but we have to clarify as much as we can in what consideration should be taken when you decide to include vitamin A supplementation in the PIN. So some countries say yes, yes, yes. Okay, while you are responding, I see Koki's hand raised. So Koki, go ahead.
Thank you very much. You can hear me?
Yes, yes. Go ahead, please.
Yes, yes. So I just wanted to type, but then I thought probably it might not be clear. So when I came to Afghanistan, and even currently, I don't know how to put it better, but there's increasing pressure from OCHA that preventive activities for nutrition should not be included under humanitarian. And you understand in the country, we have what we call the basic human needs or development. And so increasingly, it's perceived that MNP, BSFP, even MIYCN to some extent, it's a big fight usually to prove that these are life-saving. So first of all, I think I like this revised SAF criteria, but also how do we push back, especially if you can support us from the global level, because increasingly, and I know this year it will be the same conversation, where even the most critical preventive activities are being perceived as not being humanitarian. And it's not like we have, an able Ministry of Health in place that is able to implement. But what they are asking is the same partners, whether the agency or the NGO should ask for the money, but under another stream. Thank you.
Thank you, Koki. Yeah, of course, like every aspect of the HNRP, there is back and forth. Sometimes because of lack of clarity on the guidance, sometimes simply because maybe the OCHA person leading the the HNRP exercise in the country do not have really the most recent information. But in any case, as far as you are concerned and we are concerned, we only stick to the GF guideline, which has, in my opinion, has clarity on what needs to be included, what shouldn't be included. Now, in terms of determining what services can be included, as HRP, it is a individual clusters decision. There is nowhere in the GF which says, these are the list of services you need to include. No, that was deliberately excluded from the discussion because this falls under the clusters mandate. So our mandate is, of course, to make sure that we focus on humanitarian needs. What are considered as humanitarian needs within the nutrition sector? For example, taking vitamin A supplementation, covering 100% of the vitamin A supplementation need is not within the mandate of nutrition and emergency, right? I hope this is clear for everyone. We are responsible for covering the gap. I want to repeat this, the gap, right? So we are only responsible for any need for vitamin A supplementation that has not been met by the regular health system. In almost all contexts, we have some kind of functioning health system. Even in extreme situations, there is some health system, right? Whether it is, in most cases, a government run, in most cases, there is some government provided service, whether it is supported by development or humanitarian donors, that's another discussion. But in any case, there is a health system. Within that health system, there are preventive services that are expected to be provided using facility level static service as well as through campaign. Vitamin A is one of them. And this, by the way, applies for IYCFE services, MIYCN services. These are part of a package of routine services, or things like vitamin A supplementation could also be provided as a campaign. Now, it is very important that our role is to cover only the gap. For example, a typical case is, let's say there are some displaced people, and among them we have children under 5 who missed the most recent vitamin A supplementation because they were on the move and there is nowhere they can be covered through the supplementation campaign. So what we do is we need to include them as a PIN. Or you may have some area which is the epicenter of a conflict, and there was a complete disruption of services for some period of time, and the children on those area, in that particular area, couldn't receive routine supplementation program or couldn't receive vitamin supplementation through the campaign. So in those kind of exceptional circumstances where there is a gap in access to these services, like vitamin A supplementation and IYCF services, we can include this gap. We are not meant to include the whole caseload. This is not within the mandate of nutrition emergency response. So I hope this clarifies the first 2 bullet points, whether or not we should include vitamin A supplementation 100% or IYCFE. Okay, before I move to the next 2 bullet points, I think Isaac raised his hand. Isaac, please proceed.
Yeah, thank you very much, Anthony. I know we had the bilateral discussion. Thank you for your
of course,
clarification.
A lengthy discussion.
Your clarification during the cluster meeting last week. I think it was on the 1st of September. Now, there are some issues which I think is good for you to get some kind of guidance. some of the reflection we're getting from the stakeholders or partners that look, what happened that, okay, if last year, for example, we had money for 2025 and we covered maybe 50% of the vitamin A supplementation, and now we don't have any money for next year and we are planning for 2025, what should we do? Because we are basing on what is the experience for this year, that we may have covered, for example, 10%, 20, 50% of vitamin A in it, and we have a gap of those, maybe 40 or 30%, this year. But we're now planning for 2026, and we are not certain, we don't have money. In terms of planning, why shouldn't we take it 100%? Maybe if you're reflecting on that, Anthony. Thank you.
I missed the last point. You said, why not take 100%?
Yes, that's also some of the reflection we're getting from the stakeholders here. And we had a kind of meeting that, okay, the gap we are talking is for this year, and we are not certain whether we're going to be getting the money for next year. You see?
Yeah.
We have reached 50% this year. And if we're planning for a gap for 2026 and we don't know whether we're going to be getting the money and we don't have any assurance of money, why shouldn't we include them into the PIN? Over to you, Anthony.
Yeah. So I had a couple of meetings with you, with your partners over the last week. So the question, just to make it clear for everyone, is, okay, what if the gap is as big as 100%? Do we just ignore it, or what do we do about it? I guess that's the question. Like, what if there is a complete inability of the health system to provide these routine services through campaign or routine services? This is a very important question and important aspect to consider, but this is beyond really sectoral decision, right? This should be brought to the attention of the HCT, because they have to make a collective decision which will expand the scope of the HNO. Meaning, remember, in the scope of analysis, when we designate affected areas, we looked at only areas that are directly affected by the shock. What if there is a complete collapse of the economy? In this case, complete inability of the Ministry of Health of a particular country to provide basic services. What do we do? In such situations, we do have example where the humanitarian mandate is expanded a bit, including provision of some services which are normally considered as routine. So my answer to this is that in that kind of circumstances, in this kind of context, I think this is important to bring to the attention of the HCT, and HCT makes a decision. And when they do so, at the end of the day, HNRP is a strategic advocacy document. It goes to the donor community. They need to understand that the level of service gap is basically 100% of the routine need. So if that kind of understanding is there, and there is a consensus among all sectors, and the HCT decides, HCT in most cases also as a resident representative, if they view the situation as a complete collapse, that's a different discussion. But we are talking about a typical HPC country where our mandate and role is more of the gap rather than the entire need. So yes, Isaac, your point is very valid. We have seen some situations in which there is a complete collapse of the health system. In that kind of situation, these exceptions would apply, but this is the decision beyond our sectoral level analysis. It has to be decided by the HCT how wide the scope of the analysis should be. So I hope this answers your question. I hope also
100%.
other people have similar questions. Yeah.
100%.
Okay,
Thank you very
Lena
much.
is asking, how can we avoid double counting? Okay, I will come to that. How we can, there was also a point recommendation from Geraldine in which she highlighted how to avoid double counting. Well, when we aggregate the total PIN, if the population, the target group is overlapping, we take the higher of the figures. For example, if you have let's say for children under 5, let's assume in this case we have 100% coverage of vitamin A supplementation, even let's say 50% or 30% people in need, which is the 30% of the vitamin A supplementation need is included in the PIN, let's say as a gap. And you have a SAM admission, which the CMAM admission PIN or the CMAM need, which is also close to the vitamin A people in need, but the vitamin A people in need is higher than the CMAM need. In that case, you just take, because the groups are overlapping, these are the same group, 6 to 59, and of course, you may have inpatient cases for some treatment, but if the target groups are overlapping, you could take the higher of the two in order to avoid double counting of the same group in the PIN aggregation. But the easiest way is use the GNC tool. It can automatically exclude double counting. It makes the aggregation easier.
Hello, Antony. We had a
yes.
hand raised from Helena. Hello,
Helena, you can go ahead. I don't see
okay, I think,
the hand raised.
can you hear me?
Go ahead.
Yeah, I
yes,
think you
Helena, go ahead.
you responded to that question. But what we do is, we include IYCF in screening, but we don't add it up with the PIN. So we will show the figure on our calculation, and we also do the the finance or the funding requirement for IYCF and screening, but we don't add it up with the PIN. So that's how we're working before. So I'm not sure whether that's correct or not.
That's correct. If the target group is overlapping, you take the higher of the two, or if there are 3 service packages, 3 service types, but their target group is overlapping, you take the higher of the 3. So that's just simply the general recommendation. And now the other frequently asked question is, how about adding the MUAC screening to the PIN? And this number is usually very high. And also, there is no guarantee that we are not, the MUAC screening, one child could be screened like twice or thrice, who knows? So counting the number of MUAC screening is a complicated task. And also adding the MUAC screening, it also, to some extent, overestimates the PIN. So it is, I would say, in order to avoid any complication in our overall estimation, is better to avoid including the MUAC screening in the people in need, because one, we do not have any control about how many times a child could be screened through the MUAC screening. Number 2, also from our nutrition community, it's not clear, based on the knowledge we have now, is MUAC screening part of the CMAM service, or is it a standalone service? And, those issues are not resolved yet, and it will raise also a lot of questions within intersectoral discussion. So it's better to avoid including MUAC in the PIN. And number one, it's a very high number. Number two, we do not have any control on the number of times one child could be screened in a screening campaign. Okay, the last one. If we have IDP population and we do not have previous data or pre-crisis data on the nutrition level, or we do not have most recent data on, let's say, the prevalence of GAM or any nutrition indicator, how we can estimate the PIN? Because as we discussed earlier, we include the IDPs, especially when they are of significant number, in the PIN or in our need analysis, nutrition need analysis. But how do we estimate the PIN for this group in the absence of data? I think this is a very common question. The short answer is usually the common practice is you take the percentage of children under 5 and pregnant and breastfeeding women in that population, and you take that as a need. This is like the highest possible people in need for nutrition among displaced population. So if it is 20%, take 20% of displaced people. If it is 25% based on historical data, you can decide. But usually between 20 to 25% of the IDPs, we consider that people in need for nutrition needs in emergency for displaced or IDP population or people on the move. All right. So do we have any other questions? Okay, I see John's comment at the chat box. Has the use of combined GAM in PIN estimation been standardized as normative or continue to be decided? Okay. Combined is now accepted. If you have a combined GAM, you can use it, because depending on the country, if your admission data is based on the weight for right or the MUAC, then you can use a combination of combined data, combined GAM, and I guess there are quite a number of countries who are already doing this. Next slide. So now we move to the response planning aspect. We look at two major areas briefly. One, how do we set target? Especially this year, this is important to know what percentage of the PIN should be included in the target. And of course, the other aspect is the costing strategy. What kind of costing strategy? Is it project-based or activity-based that we should consider applying in our HNRP in our countries? Let's continue. Next slide. So the HNRP guidance, which was published recently, which I shared at the beginning of this webinar, it clearly states that the recommendation on the left side of the screen, which is people targeted, the proposed formula would be people targeted is equals to 100% of the PIN in phase 4 and 5, and maximum 50% of intersectional PIN in phase 3. So the maximum you could go if you are setting a target is phase 4 and phase 5 areas plus 50% of phase 3 areas. So this is the global HNRP recommendation. So if you may have phase 3, phase 4, phase 5, in the past, in some countries, we include 3, 4, 5 as a priorities, but this year, the global guidance says you could include 100% of 4 and 5, and maximum 50% of phase 3. And within that also, you can see on the right-hand side, the right-hand arrow, within this target, you could also be prioritizing only phase 4 and phase 5. So very restrictive kind of prioritization for HRP this year. So the same logic applies, the same recommendation applies for nutrition. Primarily, phase 4 and 5, they are automatically included, but you can also include 50% of phase 3 as your priority. But again, as you all know, HNRP there is a lot of back and forth, a lot of discussion, negotiation with the intersectoral mechanism with the HCT. You may be, pressured to only target phase 4 and 5 based on this global recommendation. Of course, you have no option but to follow the global guideline. But we have also additional consideration as far as nutrition is concerned. We can go to the next slide. So our recommendation, general recommendation, based on the sphere standard and based on the GNC guidance is, as much as possible, try to achieve 50% coverage in rural areas, which is typically the case, at least minimum 50% targeting of the need, 70% in urban areas, and of course, in a camp, especially formal camp setting, you could use 90% as your target. So we do have our own sector-specific recommendation. I hope the same coverage, this coverage applies in phase 4 and phase 5. But if you have the capacity and the resources, you could also go to 100% of the need in phase 4 and 5. So this is just a general recommendation, but what percentage you need to aim for targeting, it depends on, as usual, capacity, resources, funding prospect, and several other practical feasibility considerations. But for now, the general global recommendation is include only 4 and 5. In exceptional cases, you could go up to 50% of the need in phase 3 areas. And for nutrition, yes, follow this global guideline, but at the same time, also make sure that at least you are able to achieve 50% coverage in all nutrition service packages.
Hi, Anthony. We have a question from Huda. Where
Yes.
Now that they're in a war zone, is the target the same?
So if it is war zone, it's very likely that the severity phase is phase 4 or phase 5. I mean, it's very likely. I mean, Huda, yes, like in Sudan, I'm sure you have a lot of areas of phase 4 and 5. For those areas, there is no problem. The targeting could go up to 100% of the need, and 4 and 5, there is no issue. The difficulty we are going to have is phase 3 areas. And normally we include phase 3 areas in the past, but that is very unlikely to be accepted this year. But yes, Huda, in Sudan, yes, war zones or conflict zones, they are very likely to fall under 4 and 5. And I don't think there is issue in including those as top priority or even using 100% of the need as a target there. Kibrom is saying there is high pressure on prioritizing targeting due to severe shortage of funding with some compromise meeting. Yeah, of course. I mean, we are living in a changed context, funding context. This is obvious to every one of us. Yes, these minimum standards may not apply, practically speaking, at this very difficult time. But at the end of the day, we need to always advocate for this level of coverage, minimum this level of coverage. Whether or not that is acceptable is a difficult question to answer. But it's obviously challenging time to advocate for a very high coverage, which will result actually with high financial requirements. How can I ensure that IDP's data is included under people in need and set updates their target along its mine, even within the same year? Is this procedure correct, appropriate guidance? Well, IDPs, as I said earlier, you can automatically include IDP need within the nutrition PIN. When you do so, if you do not have past or most recent data on the level of acute malnutrition or other nutrition needs, you can just approximate the people in need by taking, the proportion of children, total number of children and pregnant and breastfeeding women among the IDPs. The usual percentage is around 20%, but sometimes it may go up to 25%. So you can just take 20 to 25% of the IDPs as people in need for nutrition need in the IDP areas. Okay, next slide, please. There is one slide missing, but let me just talk about costing. So as far as costing is concerned, you can use, depending on the country, we cannot say, use one or don't use the other. There are two ways of costing. One, all your partners submit projects, and those projects are peer reviewed by your cluster peer review team, and you add the value of those submitted projects, and you come up with your total financial requirement. I think this is not really the most common practice in recent years in most countries. The other costing option is using per capita or activity-based costing, which is you have a per capita cost for a certain service. For example, if you have acute treatment of severe acute malnutrition, the per capita cost could be $100 per child treated. Then you multiply this per capita cost with the number of children you are targeting. The GNC tool provides all these features. You can look at that. So in general, you have activity-based costing, and secondly, you have the project-based costing. Depending on whichever approach the intercluster decides in your country, you can follow one of the two. Or sometimes there is also a hybrid approach where projects are submitted at the same time also per capita costing is used by the partners. So it's just follow your intercluster decision at the country level. Okay, finally coming to maybe additional considerations. This is additional cross-cutting considerations. We have a number of guidelines which we have been sharing in the past, like guideline on incorporating AAP considerations in HNRP, localization, GBV, and protection. We will be sharing those materials with you. And this is just a reminder that these are compulsory, and make sure that AAP localization, GBVN protection, disability, all these aspects are incorporated in the HRP. I guess we came to the end of the webinar, and if there are any questions not addressed, or if there are any final questions you would like to raise, we can take a couple of minutes. Let me also read some comments at the chat box. Geraldine, OCHA has sent a message today that activity-based code. Okay, Geraldine, I didn't see this message. Maybe you can you clarify this to everyone? And I didn't check this most recent message. I only saw the guideline on the HNRP guidance note shared, I think, a couple of weeks back, but I haven't gotten this most recent recommendation from OCHA. Please go ahead, Geraldine. Are you unmuted? Shabib, Isaac, can you help me unmuting Geraldine?
Yes, she can. She can talk.
Can you hear us, Geraldine?
I can talk.
Okay,
Yes.
okay, go ahead, please.
Thank you. Yes, Santene, that's due to time difference. You will find it in your inbox because you are in Canada, but there is a document circulating right now that OCHA is writing down a document to advise country to use activity-based costing for the upcoming HNRP, and they are asking us for a red flag, revision of the document. So official, let's say, communication will go out in the coming days, but that's heads up for our colleagues in country that activity-based is likely to be highly recommended. So don't hesitate to reach to us for tailored advice if it's a new approach for you. Thank you.
Thank you, Geraldine. Thanks. So yeah, activity-based costing is recommended. Of course, one point I forgot to mention in the guidance issued by OCHA is they want to make the process as light as possible, so less complicated than usual. So activity-based costing, especially for nutrition sector, is a very less hectic and less complicated process. So it's good that activity-based costing is recommended this year. Yes, Koki, yeah, activity-based costing is unit costing, yes, per capita costing. So unit costing meaning the cost per targeted individual. Yeah. Okay, Isaac.
We have a hand. Okay.
Antonio, thank you very much. Yes, thank you very much, Antonio and the team. I just want to ask you if you can include the recommendation of the exceptional circumstances where the HCT needed to approve the consideration of of maybe vitamin A, for example, or any other kind of, it can be micronutrient. Vitamin A is just an example. But if you can put it as part of this guidance, I think it will be very useful. Thank you very much. I need to run to another meeting as well.
Thank you so much. So thanks also for reminding me something. So what we would do, as you have seen today, we were trying to address the most commonly frequently asked questions. So after this webinar, we will be, over the coming couple of days, we will be sending you FAQs on HNRP, and it will address the most common challenging questions and how to address those challenging questions in the HNRP process. And also in your specific country case, if you have any specific question, as usual, please feel welcome to reach out to us, and as usual, we provide one-on-one support each country.
Thank you
So
very much,
with
Anthony.
that, yes, thank you, Isaac. Thanks for joining. With that, we wrap up today's webinar. Thank you for joining. I hope it is useful. And I would like to thank you all for your active participation. And I'll also thank Isaac and Shabib for co-facilitating this session. And thank you very much. And we will be sharing the webinar recording and supporting material and other useful resources. And we will reach out to you one-on-one to arrange for one-on-one support. Thank you so much.